Welcome to Physician Education for Smart About Safety. This is Lourdes Memorial Hospital education program for physicians regarding our culture of safety. This is based on a behavioral approach to a safety culture, and this version was prepared for physicians using case studies from all specialties. There are three objectives to this presentation. You will learn about building and sustaining our safety culture, understanding how errors and events occur, and you'll learn safety behaviors to help reduce the event rate. This participation in this event is sponsored by Our Lady of Lourdes Memorial Hospital, accredited by the Medical Society of the State of New York to provide continuing medical education for physicians. It is designed to give you a maximum of 1 AMA PRA Category 1 credit for participating in the entire program. Today's objectives are to explain how institutional culture affects individual behavior, which affects patient safety, describe how and why people experience errors in complex systems, and identify the safety behaviors and error prevention tools that go along with each behavior and use them in practice. If we think about how error occurs, the Institute of Medicine wrote a paper called To Err is Human and realized that 44,000 to 98,000 patient deaths occur each year due to medical error. And unfortunately, in the 14 years ensuing this documentation, that event rate has not changed significantly. 298,865 patient deaths occurred between 2001 and 2003 due to patient safety events. 380,000 preventable adverse drug events occur in hospitals each year. This number, however, has been reduced with the advent of electronic prescribing with automatic checks for interactions. Recommended care is received about 54% of the time based on chart reviews. So if we review a patient's care model, we will see that only 55% of the time the recommended evidence-based care is received by patients. All cases of patient harm are tragic. In the Institute of Medicine's report, again, we estimated that nearly 100,000 patients die each year because of human error. This would be one patient every 5 minutes and 22 seconds. When the Institute of Medicine published their report, many healthcare providers thought the estimate was too high. But reviewing by an independent organization, Healthgrades, again reflected that this patient event rate was sustained. We have a tragic case of Josie King, who was an 18-month-old who died of a third world disease, dehydration, in the best hospital in the country. What do we do about this? Lourdes is using a proven approach to improving patient safety. We can see by instituting a culture of safety and a significant safety program, you can reduce the event rate. This is demonstrated in this. At Lourdes, our serious safety event rate, by instituting the Smart About Safety Culture program, has reduced our event rate significantly. Since we began tracking, we have now had 510 days as of July 2014 without a serious safety event, and we continue to promote safe behaviors throughout our institution. So why do events happen? These occur because of active errors by individuals. How do you prevent this? By defending in depth. If we think about safety events, a serious safety event is an event that reaches the patient and results in death, life-threatening consequences, or serious physical and psychological injury. A precursor safety event is an event that reaches the patient and results in minimal to no harm. A near miss is an event that almost happened, but the error was caught by one last detection in the barrier. Of the acts that cause harm, 59% were caused by culture, people and interactions of people, or active errors by individuals. Critical thinking is not what we know, it is how well we apply what we know. Normalized deviance is defined by the situation in which noncompliance becomes a practice habit. Attention to detail is literal when we are not paying attention. Communication and lack of poor exchange of information also results in active errors by individuals, which can result in harm to the patient. If we look at this model, it's called the Swiss cheese model, which was developed by a British psychologist, James Reason, who was studying aviation safety events in the United Kingdom. Complex systems fail in complex ways. The healthcare system is designed in many ways to defend in depth with multiple barriers to prevent harm from occurring to the patient. The barriers are invariably imperfect, which is shown by the holes within the model, hence the name Swiss cheese. In order for a harm to occur, a system must be triggered by an active error and experience a total breakdown of all the barriers in the system intended to prevent that error from reaching the patient. Safety is defined as an absence of harm. Patient safety is then defined as no harm to patients. Events are the enemy of a complex system, not human error. Human error is only undesirable because errors can lead to events. On average, a sentinel event is the result of 8 human errors. Active errors trigger the system. The system, represented by a series of barriers against that error reaching the patient, works to find and fix the active error. We all know from working in the system that the system is not perfect. You can think of an example of a patient with a similar name who may be admitted to a hospital unit, placed in a room next to a patient with a similar name. A provider calls to have the patient sent down for a procedure and asks for Mrs. X in the room. The nurse, if they're not paying close attention, may give information about Mrs. X in another room. And if the patient further complicates the matter by being moved to a different floor and the provider is not notified and calls asking about that same named patient, you will find that an error rate can occur because information is given about the wrong patient. We know that system errors like this happen every day within hospital systems, and the way to try to prevent this again is to build appropriate barriers within the system. So how do errors happen again? The design of the culture, design of technology, the design of processes, and design of the environment of care all impact behaviors of individuals and groups, which lead to outcomes. There are 3 ways humans perform. We have knowledge-based performance, which is the figuring it out mode, rule-based performance, which is the if-then response mode, and skill-based performance, which is the autopilot mode. Skill-based errors happens when we are slipping or lapsing and not really paying attention to what we're doing at the time. So again, we're doing tasks that are so routine and so familiar that you don't even have to think about the task while you're doing it. So again, a skill-based performance is a skill pattern that exists in your brain cued by something in the environment. A slip, without intending to, you do the wrong thing. So you get in your car, you drive to work. It's now Saturday morning. You don't usually work. You get in your car and you drive to work. So without intending to, you did the wrong thing. A lapse, without intending to, you failed to do what you meant to do. You took the milk out of the refrigerator. You intended to put it back in the refrigerator, but you left it on the counter instead. That would be a lapse. That's stop and think before acting. Or another example would be you intended to write a prescription for the patient. You were distracted and failed to do that. That would be a lapse. 3 in 1,000 acts performed in error are this type of error. Rule-based error. Again, a rule-based performance, the brain is looking for a rule and you apply the rule. Experts live in rule-based thinking. They know what to do and stop when they don't know what to do. So again, you choose to respond to a situation using a rule you were taught or told or learned through experience. The problem with this is that if you use the wrong rule, you were taught or learned the wrong response for a situation. This is where we get into the habit of see one, do one, teach one. If you're taught the wrong thing, you'll do the wrong thing and you'll teach the wrong thing. So you need to be educated about the correct rule. These are learned from operating principles or rules. And the rule is often bigger than the policy or the law. Rules describe our knowledge of how the world works. We have rules for everything. Oil and water don't mix. Everything that goes up must come down. Never tug on Superman's cape. Don't spit in the wind. Again, rule-based errors occur in 3 varieties. Wrong rule errors occur when the wrong answer is learned as the right answer. For example, Columbus discovered the New World for Europeans in 1493, but we say Columbus sailed the ocean blue in 1492. We believe that Columbus discovered the New World in 1492, but actually it was 1493. Misapplication of correct rules occur when thinking becomes confused. This is not a knowledge problem. It's not about what you know. It's about a critical thinking problem. For example, if you spell most, coast, and boast, and then ask what do you place in the toaster, people say toast. That's not correct. You place bread in the toaster. So again, if you use the wrong rule, you need to be educated about the correct rule. If you misapplied a rule, you knew the right response, but you picked another response instead. Think a second time. If you chose not to follow the rule, this usually occurs because you thought not following the rule was a better option at the time. Then you have to reduce the burden, increase risk awareness, and improve coaching. 100 choices made in error with this type of rule. Knowledge-based errors. This is the I'll figure it out on my own mode. We'll talk about each mode of human performance in the next following slides. What are you doing at the time? You're solving a problem in a new, unfamiliar situation. You don't have a skill for the situation. You don't know the rules or no rule exists. So you come up with an answer, kind of using what you know, by taking a guess or just figuring it out. These occur when we just really aren't sure about what we're supposed to do. So knowledge-based error would be something like, what is 4 plus 4? The answer is 8. That's rule-based, very fast and accurate. What's the volume of a cylinder 4 millimeters in diameter and 8 millimeters tall? This is knowledge-based. It's very slow and relies a memory of middle school math. The probability of a knowledge-based error is 3 in 10, or 30%. Self-detection probability is only 11%. As healthcare workers, we spend the majority of our time as experts and in rule-based performance. Healthcare loves knowledge workers because they're rule-based. Healthcare does not prefer knowledge-based workers because the error rates are so high. So make your rule-based judgments alone. Make your knowledge-based judgments with friends. So if it's a rule, make sure you're following that rule correctly and that you know the correct rule. If it's a knowledge-based error, make sure you get a consult. If you come up with the wrong answer, you need to stop and ask an expert who knows that right answer or the correct answer. If you're not sure, ask. This moves on to collaboration. In a book called Why Hospitals Should Fly, John Nance, JD, states, the trick is understanding that only a special type of teamwork and camaraderie can catch in time the types of medical errors a hospital will always generate. In other words, what we can accomplish as a team of mutually respectful and supportive colleagues, checking one another for common good of keeping our patients safe from unnecessary harm, we could never accomplish working alone. We call collaboration a level that's significantly higher than cooperation. It's a shared understanding, open communication, mutual trust, and tolerance of differing points of view. That means trusting that when the nurse comes and asks you a question, that you respect her or him enough to answer that question and explain what is going on. It's the essential part of any highly reliable organization or HRO or process. It's mindfulness. That means you're consistently watching out for each other, not to point fingers and blame, but to obtain input and have collaborative agreement on how to manage our patients. That means readily adapting the behavior in the interest of the goal. If someone comes to you and says, Doctor, did you mean to enter this order? Rather than saying, of course I did, I'm the doctor, explain why. There may be a valid point that needs to be addressed. This is called 200% accountability. That means not only are we looking out for ourselves, we're looking out for each other. And if you see someone struggling or having a problem, that you assist them. What is our patient safety toolkit at Lourdes? We have 3 patient safety behaviors. One is to pay attention to detail using STAR, patient personal peer safety, which is a peer check using ARCC, which we'll describe in a minute, stop and resolve an uncertainty, and comply with red rules. The third one is clear and complete communications, using a questioning attitude with QVV, SBAR for patient concerns, and 3-way repeat backs and readbacks with clarifying questions and phonetic numeric clarification. So number 1, pay attention to detail. That means as much as we multitask, please pay attention to the task at hand. Focus your attention before you act. Why do you do this? To avoid unintended slips or lapses, to reduce the chance that you'll make an error when you're under time, pressure, distractions, fatigue, or stress, and use an error prevention tool called STAR. Stop, just stop for a second, think to focus on the task, act and perform the task, review to see if you did it right. You're admitting a patient. take the time to stop and pause for a second. Make sure that you've entered all the orders that need to be entered. Act on that and review to make sure that you've done everything that you need to do correctly. The second is called patient, personal, and peer safety. What should you do? Help others do the right thing. This is all about team-based performance. Why do you do this? To help everyone perform at their individual best. To help our team perform at its best. Just to make sure that we are able to take the best care that we possibly can. This means situational awareness. Paying attention to what's going on around you at all times and not just on the things that you are focused on. What are the error prevention tools? Peer checking with ARCC and speak up using ARCC. That means you want to look out for your team member, offer to check the work of others, point out unintended slips or lapses, point out work conditions or hazards that your team members may not have noticed. Support your team member by coaching. Encourage safe and productive behavior 5 times, but only correct safe and unproductive behavior once. How do you speak up for safety using ARCC? It's a responsibility to protect in a manner of mutual respect. It's an assertion and escalation technique that is respectful. Again, using the lightest touch possible, ask a question. Are you sure you meant to order that medication? Make a request. I'm concerned that may not be the right dosage. Would you mind checking that again? Voice a concern. I'm concerned that this is not the correct medication for this patient. If no success, use the chain of command. Our safety phrase is, I have a concern. When we're working together, we have to make sure we're looking out for our team members. You want to make sure you're correcting unsafe and unproductive behaviors. For example, approaching a colleague who did not wear personal protective equipment when entering an isolation room. Encouragement. Thanks for washing your hands. That was great. The next portion is to know and comply with red rules. What is a red rule? A red rule is something that requires you to stop and think, a clear, discrete, decision-based act that is critical to safety. With red rules, you must stop immediately and communicate what the error is in order to prevent harm occurring with the patient. Here's a case in point. A 10-year-old child with hemophilia required 2 units of packed cells because of a soft tissue bleed. The harried nurse, pressured by needs of several ill patients, decided to administer the first unit without finding a peer to double-check the unit was the right blood for the right patient, contrary to hospital policy. The patient received the wrong blood and experienced a severe hemolytic reaction. A red rule is that you cannot start a transfusion without a check. Communicate clearly. What should we do? You want to speak the language of safety at all times. Communicate in a complete and accurate information in timely and appropriate manner. Why? Because we have to make sure we really heard things correctly, ensure that we understood things correctly, and prevent wrong assumptions and misunderstandings that could cause us to make wrong decisions. The error prevention tools for this are questioning attitude, SBAR, 3-way repeatbacks and readbacks, clarifying questions, and phonetic and numeric clarifications. We will go through this in a few minutes. So what is a questioning attitude? What do? You use your good judgment at all times and ensure your actions are the best. This will reduce the chance that you'll make a mistake in a high-risk situation and ensure that risk work activities are stopped when uncertain or unsafe conditions are identified. The error prevention tool is Qualify, Validate, and Verify, QVV. Qualify. Is that source of information reliable? Is it accurate? Is it complete? Does it even remotely make sense to you? And can you verify it with an independent, qualified source? The Validate, an internal check. Are all your little red flags going off? Does it make sense to you? Is it right based on what you know? Is it what you expected? Does it fit in with past experiences or other information that you have? And your experiences or information may be incorrect, but if your internal detector goes off, validate the information that's in front of you. Get in the habit of asking yourself these questions every time. It only takes a second. Are you really sure you want to go through with that? And assume that because it's a more superior, more experienced source, that they're correct. Make sure that you validate anything that is bothering you. Verify. Check with a second source. When do you verify? When your internal detector goes off in every high-risk situation and when there's a change in the patient condition or plan of care. Here's a good catch. A 9-month-old male was admitted at 4 p.m. with diarrhea and mild dehydration due to diarrhea. In the initial assessment of the patient, the charge nurse was concerned that the infant appeared more lethargic than the typical child with mild dehydration. Something didn't seem right. Even though the vital signs during her shift remained normal, she decided to check the child before leaving the hospital, discovering a diaper filled with bloody stool, a sign of intussusception. She responded to the tiny voice that made a difference. Another case in point. A building services was heading into the magnet room of an MRI suite with a blower. His co-worker's detector went off. The MRI is a magnet. Can we take a blower into the MRI suite? Sure, said the maintenance worker. It's plastic. So they proceeded into the MRI suite. The blower, having a motor with steel and iron, immediately flew to the center of the magnet, causing significant damage to the scanner and the MRI machine. So your detector went off. You want to make sure you stop. It's okay not to know, but it's not okay not to find out. Other sources for verification are policies, procedures, job aids, clinical protocols and guidelines, reference manuals, and expert individuals. Always verify in high-risk situations or when your plan of action changes. SBAR. It's quick and to the point. What's the situation? What's the problem? What's the background relevant information? What's your read of the problem of the patient? And what is your request or recommendation? We're asking for all handoffs that occur within this hospital regarding patient care occur in the SBAR format. Here's an example. Sender is a nurse. This is Lisa Reed calling from Lourdes. Sorry to bother you tonight. Receiver, physician, yes. Sender, your patient, Joey Roberts, is a 6-week-old infant admitted today with pyloric stenosis. That's the situation. The electrolyte results return just showing a potassium level of 2.5 milliequivalents per liter. That's the background. We thought you may want to add additional potassium to the IV infusion. That's the recommendation. It's a quick example of an SBAR. 3-way repeat backs. The sender. I'm calling because Jane Elgin's blood pressure has dropped to 78/50. Physician or receiver. I understand Jane Elgin's blood pressure is now 78/50. Nurse. That's correct. And you can even do another level of using phonetic and numeric clarifications. That is 50/50/50. Making sure you acknowledge what you've heard is correct is very important. So you initiate the communication using your name. The sender provides an order, request, or information. The receiver has to acknowledge that by repeating back what they heard, and the sender acknowledges the accuracy of that information. You can always ask clarifying questions in all high-risk situations when information is incomplete and when information is not clear, or if you're really just not sure what they're talking about. You want to make sure that you understand what's being communicated so that you don't make a decision based on a wrong assumption. Phrase your questions in a manner that will give an answer that improves your understanding. We often say at Lourdes, "Let me ask a clarifying question." That is one of our safety phrases. Asking clarifying questions can reduce risk of an error by 2.5 times. Encourage questions. Encourage questions by inviting questions and positively reinforcing questions when asked. Asking a question is primarily an emotional security issue. We can foster a culture of critical thinking by asking encouraging questions. Invite questions and use positive reinforcement when questions are asked. Here are 3 top statements to encourage critical thinking. Well, what do you think? Well, that's an interesting question. Let's explore this. Numeric clarifications. When the communications involve sound-alike numbers, say the number, then the digits. For example, 15, that's 15. 50, 50, that's 50. Phonetic clarifications. For sound-alike words and letters, say the letter followed by a word that begins with that letter. A alpha or apple, B bravo, Z Zulu, whatever you should use, always make sure you use a word that starts with that letter. It could be D for dog, David, or Delta. How do we make this stick? We start by making people aware. We then do skill acquisition, habit formation, and performance. This will cause an 80% decrease over 2 years, and we'll continue to reinforce this information over and over until safety